morning, everybody. I'm Sunil Rao. I'm the Director of Interventional Cardiology here at NYU Langone Health System. Welcome to New York.
Srihari Naidu, I go by Hari. I'm Director of the Cath Lab and the Hypertrophic Cardiomyopathy Program up at Westchester Medical Center, New York Medical College.
Hi, Gavin Hickey out of UPMC in Pittsburgh. I'm one of the advanced heart failure transplant docs there.
Apologies for the delay. My name is Shashank Sinha. I'm a heart failure transplant cardiologist at Innova Heart and Vascular, where I lead our shock and CIC programs.
Okay, so we're going to start off with the debate. I want to get things going pretty spicy, so let's get Hari back up on the stage, and we're going to start with the first talk, Quality Outcome Measures in Shock, a Window of Opportunity or Road to Nowhere.
So this is the first conference that's starting early, I think, in my long history, so kudos to that. Before I got here, I was trying to figure out what this conference was, so I kept Googling HFX, and I kept getting Halifax. So I'm trying to figure out, I didn't want to go to Halifax, but luckily I live right up the block a few in the 70s. So happy to be here among colleagues, people I consider really good friends. So this is a debate, but really it's just going to be a little discussion about measures in cardiogenic shock and how we can, move things forward. So quality outcome measures in shock, a window of opportunity or blah, blah, blah. And the blah, blah, blah is what I've been dealing with for the last year a little bit in terms of what to do with this. But the real question here is, is there a 24-hour window of opportunity that we can maximize through use of some objective measures of cardiogenic shock perfusion? So at the last update to the cardiogenic shock classification in 2022, this was actually a late addition to the figure. And shock is a field that we've only really dived deeply into in the last 7 or 8 years since the definition, I think, and the shock courses. So a lot of these things make common sense. And so, for example, we knew that when people come in and they're very sick, they go through stages of shock. They don't just come in one stage, but they may get worse, they may get better. And of course, it makes intuitive sense that you want to keep patients from getting worse, and you want to be able to address that and notice that in a timely fashion and try to keep them lower as possible. So you see on the right side, you can see you rapidly deteriorate possibly, or you can go through the different stages where you get worse and worse despite your best efforts. But on the other side, these patients improve. And as they get improved on therapy, they stay in stage C, and then if they get better, they can go to stage A, and then obviously they become this chronic cardiovascular disease condition, which physicians here right before had talked about the whole epidemic of heart failure. How do you get these patients back to a stage where you can then manage them on GDMT and maybe they meet other criteria for other advanced therapies down the line, or they recover. Then we realized, and this is from the Mayo database, that it's not just enough to have a patient survive. Patients who survive to discharge have variable outcomes depending on how bad they were in the hospital. So the worse SCAI shock stage classification you were in the hospital portends worse hospitalization down the line and worse mortality down the line up to 1 year and probably beyond. And so we started wondering why this is the case. We pat ourselves in the back that when patients leave, we're happy, but they're handed off to our heart failure colleagues, and they know that the patients who are very sick in the hospital tended to do worse and have to have more aggressive therapy and more potential opportunities for advanced therapies down the line. When the DANGER trial came out, we also saw the same thing, which is that even among survivors, the curve started to separate, meaning that in the Impella arm, patients continued to do better, and in the standard of care arm, patients continued to do worse. And you can see it kind of flatlined in the Impella arm and continued to have incremental worse outcomes in the standard of care arm. And so some of the discussions here we were not sure why that was, but I mentioned this in a TCT article at the time, which is that it makes sense that not all survivors are the same. And if you have a more severe case of shock that you survived from, chances are you had more damage to different organs that resets you at a lower point in your life expectancy than someone who did not have that kind of damage. We like to think that we reset completely, but really there is damage that accrues, just like natural aging. And then early data showed also that it's not enough to say what your stage was when you came into the hospital, but that what you did in that first 24 hours made a lot of difference. If you're able to maintain from C to C, or D go down to C, or E go down to C, survival automatically stays very high, up to 80%. And that's dramatically better than the overall survival we see in shock of 40 to 50%. So there's something that's going on if you can keep these patients at lower shock levels and well perfused, certainly within the first 24 hours. And we used to think that this was not the case for stage E, but even in recent data, we suggest that if you can do it even in stage E shock, 62% of these patients will survive if you can rapidly get them down from E to C or below. and only 30% ultimately meet their demise through that. So what is the final gap in shock care? We always talked about the phenotype, the etiology, the diagnosis, the severity. But one thing we left out of the room was that all these things had to be done very quickly. We knew that at the bedside, that if you don't do things quickly, patients get worse. If you leave them to their own devices, patients get worse. Shock is a declining organ system situation where it begets more shock and more hyperperfusion, and then you get into situations of inflammation and permanent end organ damage that takes them off the table for advanced therapies. So what does focusing on time do? Well, if care is fractured in your system, it organizes the system and triggers a shock team. If it's detected late, well, using something to detect it objectively and early makes sense. If you have impaired access, triaging and transfer to higher levels of care makes sense in a timely fashion. And finally, if you have variability in care, you can have things that are more goal-directed rather than process-directed all the time, but what you do, not how you do it. So this brings me to the case for lactate to tie this all together. It might alleviate a lot of these challenges to shock management in the acute setting, and the case for a time limit. So this is a new slide I put together for this conference, and to put it together in people's minds, which is that we're looking at, is this shock and is it severe? What is the etiology and phenotype? How to treat acutely and how to treat sequentially. These are all things that have to happen, and the heart team binds all this together. But on the right here, I want to focus that time is also a variable. As you go through time in the hospital, a lot of things happen. If you don't catch them earlier, there's more complications. SIRS happens, there's more infection-related complications, more end organ damage, access site complications, circulatory complications, bleeding just accrues, hemolysis, thrombotic complications accrue, and then a lot of ICU-related complications. So it is no wonder that if you can't get these patients better in the first 24 hours, you have other things that conspire against you to increase and synergize with a worse mortality in these patients. So the case for lactate comes from a lot of observational data and one randomized trial in other areas, but the Card Shock Registry showed 2017 patients with AMI shock, baseline lactate, and 6, 12, and 24-hour lactate predicted 30-day mortality. 50% improvement in lactate, 24 hours predicted survival. The IBP Shock 2 trial, 8-hour lactate was the strongest predictor of mortality, and poor lactic clearance predictive of death. In NCSI, the lactate 12 to 24 hours after MCS predicted in-hospital mortality. And the danger shock I'll show you in a moment, the Impella arm had a lower lactate compared to standard of care, and it was cleared 12 hours sooner. The Dorami trial, complete lactate clearance and percent clearance per hour, all predicted survival, with complete clearance the strongest predictor of survival. Lots of retrospective cohorts among 1,800 patients, one increase in lactate, increased mortality 9%. 24-hour lactate clearance was strongly predicted survival, and meta-analysis of 1,500 patients, lactate clearance in 24 hours predicted survival as well. And this was also true in other literature. My chairman in medicine is a pulmonary critical care person, and when I brought this up to him, he kind of laughed a little bit that they've been talking about lactate and doing trials on lactate for a long time, and in a way, it's good that cardiology has finally caught up. We don't talk to each other as much as we probably should. But lactate elevation is a marker of mortality, and clearance was associated with improved survival in hemorrhagic shock, septic shock, and burn-related injury, and there was a randomized trial of lactate in septic shock, sampling Q2 hours lactate versus standard of care over the first 8 hours, showed an improved mortality, shorter ventilation, and shorter ICU stay. So it makes sense in actually targeting it in a different disease state, but it makes even more sense in cardiogenic shock, had an outcome improvement. This is the data from the danger shock sub-study on lactate clearance, showing that in the Impella arm, lactate was cleared to less than 2, really within the first 16 hours or so, compared to the standard of care, which was 12 hours later. And it makes a lot of sense then that if the Impella was working, how was it working? Despite the complications, it was actually also clearing lactate, reversing the shock case much sooner in patients, 12 hours sooner. That 12-hour delta may have had a big difference in the overall mortality. And the data was so strong that even the Recover 4 trial, which was unfortunately stopped, used lactate clearance as one of the guides. So clearance of lactate was a key measure potentially in Recover 4, as you see there. So this is the diagram that we came up with to look at these patients when they come in. You first make a rudimentary diagnosis of what SCAI shock stage they are, but then obviously you check biochemical markers, including lactate. If the lactate is low, then you're consistent with A or B. If it's high, it's at least C and perhaps more. And if it is C, D, or E, of course, E is very obvious, then you want to see what's going on with the lactate, checking it every 2 to 3 hours for the first 6 to 8 hours or so, so probably 2 draws, three, on admission, then 2 more draws, and that should tell you the trajectory of lactate. If the lactate is clearing, you're doing a good job, and you can just continue with supportive care, maybe even withdraw therapies, and it's important to do that. If the lactate is continuing to rise, you need to escalate care and be more aggressive and get more people involved, figure out the etiology, phenotype, what are you missing, what can you do? And in the middle, there is this patient population that may have reduced clearance due to liver failure, or they may have other etiologies of lactate elevation, as we'll get into. So what does lactate clearance really do when you start thinking about this? And this is also somewhat in retrospect when I looked at what happened once we started checking lactate. Well, it gets past physician egos to trigger the heart team right away. It gets past hospital egos to transfer patients early before end organ dysfunction. This is a big problem. It gets all patients treated similarly regardless of income, gender, or race. We don't just look at the patient, we look at their labs, we look at their objective measures to figure out, are these patients someone that we have data to improve? It gets protocols in place quicker at level 1 and 2 hospitals to transfer them to the higher level of care. Allows the first hospital to try to fix it rapidly, if not transfer. It tells us what we already know, which is that treating quickly is imperative in shock. It democratizes shock care globally and is agnostic to treatment. And it allows earlier recognition of ischemic leg and ischemic gut, because if you continue to have elevated lactate despite other measures of normal perfusion, you need to look elsewhere for what else might be going on that might kill the patient. There are downsides. My colleague and good friend Dr. Rao is going to talk about these, that there are things that reduce lactate, like MCS and hemodialysis, which can be misused or not factored well if you're not looking carefully. There's a cost to point-of-care lactate and serial measurements. There's potential but negligible harm from repeated blood draws. And it's not proven prospectively and over time yet, I believe, in cardiogenic shock. Now, it's also not a metric. A metric is different and takes many years. It should be more defined, evidence-based, actionable, globally, measurable, reliable, valid, and aligned with other quality dimensions. So we're a long way from there, but all of these metrics start as measures, and then the data has to accrue to see if they are worthwhile. So I will end with a call to action and future directions, which is that after suspecting and diagnosing shock using the classification, assessment of tissue perfusion and serial lactates is very important to work clearance within 24 hours. Prevents both inappropriate escalation of care, because if the patient's doing well, you need to leave them alone. And we see this, I think, almost half the time in the CCU when I round, which is that we go in every day to do something. But sometimes you're already doing enough, the patient's getting better, and the doing something would be sort of withdrawing care. And I don't think we do enough withdrawing and de-escalation of care in the patients who are getting better, which improves length of stay. And also aggressive escalation as needed. It should help reduce the severity and duration of shock. And as I mentioned, if you reduce that, you potentially improve long-term survival and rehospitalization. It's scalable to different hospital sizes and resources globally with simple point-of-care testing. Regional shock systems and teams should consider DLC in their algorithms, including early transfers or failure to improve lactate in the first few draws, despite local resources, and be mindful of the caveats, as I mentioned. Clinicians and healthcare systems should make rapid point-of-care lactate ubiquitous in their facilities and relevant clinical settings. And finally, retrospective data sets, prospective real-world registries, and RCTs should consider evaluation of the DLC and other potential measures to fine-tune this approach and see if there's something better, or maybe this doesn't work. But so far, over the past year, it has been, I think, widely accepted. We just have a publication coming out in the next couple of weeks from the Brown University Registry showing clearance of lactate, improved mortality. And we are now partnering with the AHA Cardiogenic Shock Registry. SCAI is partnering, and one of the proposals that was approved is to look at DLC in their registry. So I'll end at the debate, but the debates are sort of more fun. So this picture came from the SCAI marketing team when they heard that 2 prior presidents of SCAI were going to be debating. So they made us look like this. I'll leave it to you guys if you think this is funny or not, but they seem to get a good laugh out of it. But it's an interesting battle. We're both, Sunil and I are both Indian Americans. Both completed fellowship, I think, in 2004 or thereabouts. He's a Dookie. I'm a Brownie from Brown University in Duke. I'm an immediate past president versus, I don't know, sometime in the past president. And I don't know, maybe common sense versus, look at me, I'm a regular guy wearing jeans and just trying to take care of patients. And he's more interested in dollars and cents. I think he has a better watch than me. And look at that little thing in his pocket. I'm not sure what that is, but the truth is, but the truth here on the right is we're really good friends. We've been friends for a long time, but he still wears a suit and I still wear the t-shirt. Thank you.
Dr. Rao, your rebuttal.
Yeah, thanks so much, and it's a real pleasure to be here. I was actually pretty nervous when when I was told to debate Hari. I don't have any disclosures related to this, and obviously it's a debate, so these are just my opinions. I was pretty nervous when I found out that I was debating Hari, and I was talking to my wife about it, and I said, I have to come to this heart failure symposium and debate this sort of national leader. And she said, whatever you do, don't try to be witty, intellectual, or charming. Just be yourself. So that's what I'm going to try and do. But listen, I appreciate Hari's last slide, but the reality is I'm just a country doctor, okay? Hari is a film producer. Here's his IMDb page. He has a recording career that he records songs. He was the immediate past president of SCAI. I was president in 2022. But the more important thing is that he came really ready to fight here. And as he mentioned to you, he went to Brown. I went to state schools. So this is already a little bit of a lopsided debate. But what I'm going to try and do is maybe instill a little bit more common sense, as he called it, into this issue around quality metrics. Because the reality is, in cardiovascular disease, we suffer under the tyranny of QI metrics. If you look at all the sources of things that we're supposed to be tracking, it's almost 150 measures across all the systems. And the major sources are CMS, up to 40 quality measures, the ACC NCDR, which can be up to 100 plus quality measures that we have to track. The AHA has an additional 50, and the NCQA has an additional 20. This is just an unbelievable burden of quality metrics that we're being asked to record, report, and try and improve. Now, all of us know that the human behavior is very difficult to overcome. When you have a quality measure, you're going to try and reduce that measure rather than look at the overall goal of what you're trying to do. And there is the classic story of the nail factory in the former Soviet Union. Remember, in the former Soviet Union, all the factories were owned by the government. And this factory was producing nails. And they told them, you've got to increase production of nails by 200 tons next year. So what did the factory do? They met the goal. Instead of making usable nails, they made gigantic, really heavy spikes. So the government said, no, that's not what we meant. Next year, you've got to produce more nails. So what did they do? They produced more nails. Were they functional? No. They were tiny, tiny little nails, and they certainly met the quota. So you've got to be really careful about what you choose as a quality metric. And the reality is there's no difference between a quality metric and what's called a performance measure. Performance measure is the lexicon that we use in the quality improvement world. So what are the properties of a good performance measure? They have to represent a meaningful outcome to patients and society. They have to be valid, reliable, and readily measured using existing data structures. Importantly, they have to have the ability to be adjusted for patient variability. Mortality is the classic example of this, right? So if you're a center that takes care of sicker patients, you don't want to be penalized for a higher mortality. You want to be able to have that risk adjusted. Also, as importantly, they have to be modifiable through improvements in care processes. And finally, they have to be practical to measure. If you start thinking about what these qualities are, performance measures, you can kind of come up with what the limitations are and what the challenges are. You have to choose the right ones. So you have to take into account the care delivery setting. Are you talking about a tertiary care center, or are you talking about a hub center or a spoke center? If you start thinking about applying quality measures to spoke centers, they may not have the resources or the personnel to kind of meet those measures, and then they're going to necessarily look worse. And this is even has bigger implications if you tie that to reimbursement. We've seen this with quality measures where safety net hospitals have been unfairly penalized. They're not given the resources to meet them, but they're asked to meet them anyway. There also is variable interpretation of clinical trial results, right? Some people would say that the dangerous shock trial is too fragile to actually implement into clinical practice. Others say, look, it's the only trial that we have that reduces mortality, right, with mechanical circulatory support. Data quality is really, really important. Observational data has led us astray multiple times in cardiology. And so right now, all we have for lactate clearance is observational data. And lactate is a marker, not necessarily a mediator of outcome. And then, how well can we capture all the granularity of the data in patients with shock? There are a lot of unmeasured and measured confounders that go into whether or not you can actually risk adjust a quality measure in shock. And finally, there's the representativeness of the patient population. So let me give you an example. If you think about quality in terms of structure, process, and outcomes, and I'll use the cath lab as an example. Maybe the structure says you have to have the latest imaging equipment so that you can reduce radiation exposure. Okay, that's great. You've met the structural requirement. But maybe, you don't really have qualified interventional cardiologists to use the room. So you've met the metric, but you're really not using it, right? Let's say you've got a great process for identifying, patients who are at risk for acute kidney injury, and you're going to hydrate them beforehand. But if nobody is aware of the algorithm, or no one's aware of that process, you've met the metric, but patients really haven't had a good outcome. So here are some proposed quality measures in shock. The use of MCS. Well, there's only one positive trial. Should that really be a quality measure? This is my favorite one, use of right heart caths. There's not a single positive randomized trial showing that right heart caths helps outcomes. It makes sense. Should it be a quality measure? I'm not so sure. Mortality, that's a tough one, right? Because there are not that many measures to reduce mortality in cardiogenic shock. We try our best. And then D2B, which is, this should be door to balloon time in patients with acute MI cardiogenic shock. Luckily, this may be delayed due to non-system issues, and we are able to capture some of those non-system issues. So then, what about DLC-24? Does that meet the bar for a quality measure? Well, it's a marker of risk, not a mediator of outcome. It's not necessarily all that practical in measure in a registry. I was one of the founders of the HA Shock Registry. When you're asking people to measure serial lactates and then report them to the registry, think about how much work that means on the ground. Who's going to abstract all that data? And think about how often you get these lab tests. It's not risk adjustable as far as I know. I mean, there hasn't been really a good model that adjusts for risk satisfactorily. And then it's modifiable, sure, but it's not really clear if the strategy to lower it also lower the risk of mortality. Really, as lactate comes down, it just means that the patient is likely to live, to survive their shock state. So I'm not really sure that it's anything more than a marker of risk. So where should we spend our resources instead? I think we should be doing more randomized trials. And I think clinicians have to overcome our lack of equipoise in shock because these patients are very sick. We all have strong beliefs about what we should be doing, but instead we should be randomizing. We should be spending our time in early identification, and Hari has really contributed to the field by creating these SCAI shock stages. And identifying patients early in their course may, in fact, help to improve their outcomes. We should be generating evidence for MCS. What level of support is needed? We actually don't know the answer to that, which is interesting. How much support do you actually need? Is it just a question of support, yes, no, or how much support you need? And then how do we reduce those complications? Remember, in the dangerous shock trial, the patients who died in that trial had two a bimodal distribution of the timing. Many died in the first 48 hours from pump failure, but others died after 30 days from complications. And then finally, I think what's incredibly important is understanding the effect of surviving shock on the patient's caregivers. These patients tend to have long-term disability, as far as at least from what we know and what we experience. And I think it is a huge burden on caregivers to think about how to care for these patients. So in summary, cardiogenic shock is an area that we need more data. Without evidence-based strategies, no structural process or outcome measure really meets the bar, in my opinion, for a performance measure. And I think in a world where we're oppressed by the tyranny of metrics, we need a rational approach to treating these high-risk patients. So I think we should get the patients on the road to recovery, not a road to nowhere. Thank you very much.